Good morning to America, good evening to Bangkok, and good afternoon to some of the other places around the Middle East. My name is Ruben Peralta, and on behalf of the leadership of the Trauma Center here, Dr. Hassan, Rizal, myself, and the other group, we'd like to present a case, and it just came out this week, as Dr. Martos called us. We just present one of the simplest cases that we could have, and our consultant, Dr. Afifi, will enlighten us with the discussion.
Hi, good afternoon, morning, evening, whatever. So, good morning, everyone. And this is the picture for our Qatar medical city, and this is the new building for Trauma Center, 250. It's trauma and some emergency part with it. And you can see the background, also our buildings. We have a huge medical city, and the country here is really supplying and supporting the health sector supremely. So today, the discussion about the gentleman with multiple stab wounds, that time we called with Dr. Ruben, the senior consultant that day, and I was with him. So let's just starting the presentation. I have no conflict of interest here. So it's a 30-year-old male. He's presented multiple stab. The initial vital signs that his systolic is 100 and heart rate is 110. He was GCS is 14, and they think that he's intoxicated, smell alcohol. Later on proved to be alcohol is 40. There is no active bleeding from the wounds, and we did to him E-fast, showing that there is a positive fast on the left side, suggesting left pneumothorax, and abdomen fast was negative. On clinical examination, you can see here, if it's clear, the pictures. We have a left supraclavicular area, a little bit laterally, and left hand, third web space, and left forearm, and left flank. It's exactly a little bit posterior than anterior. The lab showing that hemoglobin is 9, the entropy is 22, creatinine 68, and INR is 1.3 that time, related to 180. ABG showing that pH is 7.25, O2 is 200, very good, plus. CO2 is 40, the base excess was -9, and the bicarb is 18, lactate is 2.8, and this is, of course, suggesting for metabolic acidosis. And here we proceed to the patient. We did chest X-ray to him, and maybe the picture is not clear, that's why I marked by yellow. It's a very minimal rim of pneumothorax on the left side. Stab to the flank, and the patient was stable initially, apart from the acidosis. The hemoglobin is 9. But the patient was a borderline. I think Dr. Ruben classified him like a class 2 shock. And a question for the audience and for our senior colleagues there. You like to proceed CT scan, or you want to go to the operative? Starting talk, please.
Gary, can take over.
How about Campinas, Dr. Fraga?
Good morning, everybody. Dr. Afifi, just a question. How many time from the trauma until the admission? Few minutes?
How many again?
How many, the transit from the scene to trauma, how many minutes?
Yeah, 20 minutes.
20 minutes?
Yes.
Okay. So the vital signs of the patients are okay, but you have signs of hypovolemic shock on the lab, the gas, arterial gas. But I think you have time to go to the CT, go to the CT, because you have injuries in different segments. You need to look for the chest. You have another injury in the flank. It's very dangerous, this injury in the flank. So I think go to the CT scan is the best option at this moment.
Thank you.
Dr. Fraga. Bangkok, Dr. Suba. Go ahead, Dr. Supa.
I agree with Dr. Fraga to send this patient to the CT scan because he is quite stable, even though he had anemia and acidosis. But hemodynamically, I think he's stable enough to get a quick CT scan. CT will be very helpful in this case. You can check the vascular structures of the chest and the left upper extremity, because from the wound at the left supraclavicular area, he may have a subclavian vessel injury. And CT scan of the abdomen would be helpful too, because of the stab wound at the flank. You can evaluate the retroperitoneal organ, including the left colon and aorta, for example. So I think he would benefit from a CT scan of the chest and abdomen. Thank you.
Thank you, Dr. Supa. Dr. Untrack, your comments, please.
Yes, I agree with that. It's, you know, multiple stab wounds and without any clear source and fast is not really helpful in evaluating the flank. I would start resuscitation just because his pulse is marginal and he's acidotic on the way to CT. But I agree with Dr. Fraga, and Dr. Supa that CT would be helpful. If I were to guess, I would say probably the money is at the flank, but you really should have a CT in this case.
Thank you, Dr. Untrack. Dr. Rizzoli.
He's part of the team.
Oh, thank you very much. Let's go to
No fair.
I want to make. Sorry for my dog. No, what? Yeah. Can you describe? Sorry. Can you describe the wounds? Like, what's the size of the wound on the flank and on the supraclavicular area?
The supraclavicular area is a 5 centimeter or 6 centimeter wound, and it's deeply penetrating to the muscles. Okay, and it's the cause of the pneumothorax, as you see in the X-ray. And the left flank wound is about 6 centimeter and deeply. I mean that you can put your finger easy there if you do wound exploration. Okay, so it's a very deep wound. Both of them is a deep wound and highly penetrating.
So again, I would do as commented before, start resuscitation. This patient, he does have evidence of shock. He has a heart rate that's higher than the systolic blood pressure. He's tachycardic, he has acidosis, and he has anemia. So all indications that he has suffered a significant injury. Only thing I would add would be to the CT scan is, considering what's done on the flank, I would be concerned about the retroperitoneal structures, and probably a triple contrast would be considered. I would also do a very good examination on the upper extremity, on the chest, and see if there was anything else I could find. Thank you.
Thank you, Dr. Rizzoli.
I can answer the triple contrast question first. So the triple contrast has been considered, and I agree with you. A left flank is the best for him. He should have triple contrast. But in the picture of the borderline stability, as you said, borderline stability of the patient, and the time we will give for the triple contrast to be taken, you know, it will take about 1 hour for triple contrast. You do oral and you take a rectal contrast, take 1 hour. So prefer that, and also some articles, review the article before about the contrast, the versus non-contrast, I mean that the dye for the bowel. There is still, you know, a gray zone. I mean that some people say it's better triple contrast, and some people that the negative contrast will not rule out the injury, and this is important. The negative contrast will not rule out leak. So with Dr. Rubin, we prefer that the question of CT scan or OR, then we shouldn't have a big time or consuming time the CT scan. That's why thinking about CT scan only IV, not triple. Thank you.
Thank you. Dr. Oyman, your comment, sir.
Every time I open my mouth, I risk being kicked out of here because I am going to propose some heresy. One or two heresies. One, I agree that Dr. Afifi, the triple contrast CT is being proposed as the evaluation of flank and back wounds. That's kind of like the gospel or the being proposed that this is to be. I personally found it incredibly useless. The contrast never goes too high. You are never sure if you are missing something. And so really, it's kind of a waste of time in a patient who is borderline unstable. The other thing I found incredibly useless is the classification of shock of the American College of Surgeons for trauma. In ATLS, we have the 4 classes of shock. I find that I have, at least for me, have no practical application. Either the patient is in shock or is not in shock. I think that's much more useful, and you have to make decisions based on that. I will not resuscitate this patient aggressively because if the injury in the abdomen is the cause of hypotension, have been proven that it's better to delay the resuscitation until you are in the operating room when you can get control of the hemorrhage. So the guy is doing kind of okay. I will not resuscitate him aggressively. I would probably not put even a chest tube. And I know they're saying all this and people are thinking that I am crazy, and probably are. I am. Why? Because I don't want to give him any pain that can cause hypertension. There are 2 things that can bleed here. He has a supraclavicular stab wound that doesn't have any pleural cap or anything, but still the possibility of an injury to the subclavian vessels is there. So maybe it was tamponade and suddenly we cause hypertension and the bleeding starts, and suddenly we have a situation that is more complicated. So this patient ideally will have, this is almost a zone 1 injury in the neck. So having a CT scan will be very helpful. And for the abdomen, I will need to do a CT scan because I will plan my surgery based on the CT scan. If the patient is hemodynamically unstable, I go straight to the operating room. So after saying all these heresies, I would say I will go to the CT scan. I will do like Dr. Afifi with IV contrast and see what I have. But I will scan the chest too. Thank you.
Thank you, Dr. Horman. Looks like Dr. Fraga has a comment.
I had a question for the group about blood transfusion at this moment for these patients. Do you start to give blood components or not yet, just to observe at this point?
No, this patient is pretty stable to us. We have fridge and all the bloods available. We didn't give the blood to him because of the same reason that our previous speaker, an excellent surgeon, has described to us. So we have everything under control, and that's how we approach it.
You hear us?
Can you hear us?
Yes, sir. Loud and clear. Go ahead. Okay. If no one has anything else, we'll return to Dr. Afifi, please.
Yeah, so thank you for all the comments. Really, thanks. So, of course, we're selecting to do CT scan after discussion. And one of the advantages that we have a very pump policy for the CT scan and very rapid approach. So we take him immediately, talk him immediately to the CT scan. And the CT scan and chest, lucky, we don't have any major injury, major vascular injury in the supraclavicular area. And this is, as you can see, this is the small rim of pneumothorax. There is no bleeding. It's only mild consolidation of the left lung. When it comes to the abdomen, the flank, you can see that there is hematoma of the left flank. And this is a venous flush, very huge amount of venous flush.
Active.
Yeah, actively bleeding. And also encouraging into the colon. And you can see that here also some bowel hematoma to the bowel and to the colon part. And here you can see this is how much the extravasation in the delayed phase and how much the big hematoma it's here with the patient.
The kidney.
Yeah, in the kidney, of course. This is the lower pool of the kidney. Lower pool of the kidney, it has been injured also like a grade, because classify him like a grade 3 kidney injury, maybe 4, but we don't have urine extravasation. That's why we kept grade 3 classification. And here is some other cuts that showing that the leak here and how much the retroperitoneal hematoma and the leaking had. So the patient maintaining his blood pressure during that time, and the CT scan reports by the official report showing that there is large area of contusion, laceration in the lower pool of the kidney with a large perinephric hematoma extending to the perigastric region and surrounding transverse colon. Extravasation of contrast noted the hematoma in the venous undulating face, and there is suspicious breach noted in the diaphragm posteriorly on left side. This has been picked up by the radiologist. And of course, CT scan, because the patient DCS14 has been done for the head and neck is negative. And patient was maintaining his blood pressure, and his heart rate is becoming 90. And who's the group who like the conservative, and who's the group who like the surgery? And if you like surgery, what's your aim of surgery? My question. If you want to go to surgery, what's your indication? What you are looking for based on the CT scan?
Gary?
Yes, sir. Dr. Wyman, please.
You have, I think you have to operate on this guy because you are concerned about bowel injury anyway, and he's actively bleeding. So you have two options. One that I wouldn't do, but it's an option is to go to IR, embolize the kidney, and after that go to the operating room. The rationale for this is that when you explore a penetrating wound in the kidney, usually the kidney comes out. Having said that, in this case, you have a clear diagnosis. I will take this guy to the operating room. I will deal with the bleeding first. I will do a Mattox maneuver, mobilize the colon and the kidney medially. And usually when you have an injury like this, you can control basically you amputate the lower pole of the kidney, the pelvis appears to be intact. So amputate the lower pole of the kidney, put some US stitches there, and deal with any other retroperitoneal bleeding that you might find. After that, I will deal with the bowel injury if it's present. And at the very end, if I have time, I will just look for the diaphragm. But that would be my order. So I would not do the angiography, although it's possible and it's reasonable. I think that this patient is better served just by going to the OR and doing the things in the OR. That's it. Thank you.
Thank you, sir. Dr. Rizzoli?
So, when I see a case like this, I remember a paper published by Dr. Fraga a few years ago about ureteric injuries. So I would talk to the radiologist and ask specifically whether there was any evidence that the ureter have been injured as well too, and probably something that I would look into up. Now going back to the big picture, I agree with Dr. Boyman. I would take this patient to the operating room. There's a hematoma in the colon wall, so we don't know if there is a colonic injury or not. And for me, that would be an indication for surgery. And like he said, I would prepare to repair the kidney intraoperatively, deal with the colon, deal with the diaphragm, and look for other injuries. And look at the ureter. Thanks.
Thank you, Dr. Rizzoli. Bang out, Dr. Super.
I agree with Dr. Hodgman to perform laparotomy, stop the bleeding, and try to save the kidney if possible, and look for other injuries. Thank you.
Thank you, Dr. Super. Baghdad, Dr. Andrade, your comments, please.
Yes, I agree with all those comments. And about conservative treatment, I mean, this comes up from time to time, and I think most of us give our basically expert opinion, which is the lowest level evidence, but I just would wonder whether or not there's evidence in the literature to show that that would be appropriate in a case like this. That, you know, he's in shock or not, class 2 shock, or he's in shock, and you have evidence of ongoing bleeding in the kidney, and then you're not sure about the colon. So with a patient that is you know, in shock, but otherwise okay, is young. So, you know, what would be the indication not to operate in this case? And what does the literature say about the advantages of not operating in this case? But I agree with everyone else. I think you should go to the operating room. And I assume that there was no injury to the axillary or subclavian vessels on the left at the upper end of the CT. So I'm assuming that that part is fine. Yes. Okay.
Thank you, Dr. Untrak. Dr. Fraga, your comments, please.
I think the best answer is laparotomy. It's the easier answer, but I know that Dr. Afifi, Dr. Peralta, and Dr. Rizzoli, they have an excellent trauma center. They have a good radiologist. They have a condition to have to make an angioembolization. They have our shooter to try a non-operative treatment. It's a real dangerous. The first thing to answer is about the colon. You need to review the CT, and you need to have the very security that is no colon perforation. We know there is an hematoma in the wall, but how about perforation? It's very difficult to identify by CT. Probably in Campinas, these patients go to laparotomy. But if I have the shooter that you have in Doha, probably I will try to advance with the angioembolization, if possible, and control the bleeding and observe about the signs of colon perforation. But I think it's better go to laparotomy.
Mm-hmm. Thank you, Dr. Fraga. Any additional comments before we return to Dr. Afifi? Okay, back to you, Dr. Afifi.
So thank you for everyone's comments. And so Dr. Untrak, I think the expertise in senior, when you're going to phone them, and if you telemedicine would be #1 level evidence, I will take you as level 1 evidence. It's not.
That's a formal invitation to come to see us. Okay.
So, okay. Because of this, we prefer this one to take him to surgery. At the OR table, we just, while the patient is intubated, we put to him the small pigtail catheter, not invasive one, the percutaneous pigtail catheter we put him for. We are afraid that the patient will develop more pneumothorax as the wound is sucking and the ventilation becoming highly positive. Then we go to laparotomy. And in the laparotomy, as you can see here, we found that there is a mesenteric tear. Once you have mesenteric tear with it, as Dr. Hudman, like you have been said, like looks like you are with us in the OR. So this is we mobilizing the colon in the Maddox maneuver, and we look at the colon back and forth, and lucky we don't have colonic injury, only the mesenteric injury. And then we go to the exploring the kidney, and we found that there is a 5 centimeter laceration with active bleed from the anterior wall of the anterior surface of the kidney, and we don't have any bleeding from the posterior surface to do sucking. Mobilizing the whole fascia, and we did vascular control for any bleed from the perinephric area, and then that's why we have a clear vision here of the left perineal or left kidney injury. So we're starting radiography, and we did Bridget Vacular 3.0. You can see the left side here, multiple stitches of Vacular 3.0 with the Bridget 1, so it can be able to control. And then after that, I apply fibrillary back on it, and we did closing the fascia of the kidney, and we have given some time, and there is no any bleeding that time. Then with that, we're exploring for the kidney, the diaphragm, as the report mentioned, and we found that this is Dr. Ruben finger, you know, the green one. It's showing that there is a perforation into the posterior rim of the diaphragm. So based on that, we have been sorting it was probably into 0 from the inside. We faced one episode of hypertension in the OR, systolic blood pressure coming 65. That's why the patient received 2 back dialyses. We have total blood loss of 500 ml. We called the plastic surgeon for the left hand, and then we close the abdomen, and we elect to discuss about the drain. We found ourselves afraid that maybe the patient have some urinary leak later on. So we put the drain at the perirenal area, and we tell ourselves to give it a couple of days to see do we have any urine collection, what's going to happen. And the plastic surgeon came, and yes, simultaneously, at the same time, after we finish immediately. And there is a left third web space deep laceration with cut of the intermetacarpial ligaments. And the neurovascular is intact, so the irrigation and repair has been done for him. This is our team in the COVID area, describing this one. Post-operative, the patient shifted to TICU for 1 day. He started full diet after 24 hours. Drain removed after 48 hours for nil output. Chest tube removed after 24 hours. I think 48 hours, sorry. And there is no hematuria, patient operating. We give the patient augmentin for 3 days as a recommendation by the plastic surgeon. And the patient discharged in good condition in 3 days. So this was the case management and simple one. I know that we might face some complication, like maybe later on we find ourselves in urine leak, and then that time I think we will evolving ourselves doing stenting and starting to do looking for. And so I would like to hear any final comment or like modifications of the things we are doing in the final comments. Thanks.
Thank you, Gary.
Baghdad, Dr. Untrack, your final comments, please.
Well, so a nice case, and I think you know, there was no output from the drain. So I think had he developed a urinary leak, then you know the drain would have taken care of it. If it was you know like a leak from the renal pelvis or from the capsule, and would have closed. So and then you'd have time to study him afterwards, post-operatively, if it didn't simply close. So I wouldn't be, you know, that wouldn't be a big concern. But so obviously well done. But I think the point that came up before, is there evidence in the literature, or the studies in the literature advocating in a case like this to do conservative treatment? Because apparently you could have that the bleeding that you had, the blush on the venous phase and the CAT scan, that might have stopped, and the mesenteric bleed, from what you found, wouldn't have devascularized the colon, so it might have worked. But is there any evidence in the literature to advocate for that type of approach in a case like this?
Great question, Dr. Antrak. You know, we reviewed all the studies with radiology. It was really active extravasation. When we went in and mobilized the kidney, the patient was bleeding a lot. And you can see with the pledges, that's what we can control. Is if you see the CT scan, it's in the low pole of the kidney, and it's the calyx is not involved, but a peripheral calyx could be involved. That's why we really cautiously let the intracapsular drain. But if you can see, if you can travel, you know, dynamic CT scan, you know, we only put you one photo, one picture. But if you, you know, go through in all the 3 views and 3D views, it was away, but was bleeding a lot. And around 500 cc's, we can control it quickly, with the plages and the stitches. For us, I think there was a case that if you're in the middle of nowhere, you don't have to call urology for a lot of things that, that could be solved by us. Good question.
Yeah. And also I am preparing the article for this at the end, after finish, for this question. It's a very important question. Thank you.
Thank you, Dr. Ntrak. Campinas, Dr. Fraga, your final comments, please.
Oh, excellent. Sometimes it's difficult during laparotomy to identify if there's a small injury, a small perforation in the colon. Was it difficult, or Ruby, you need to mobilize the colon, look for perforation?
Actually, our first impression was that was perforated, because the hematoma is the typical hematoma that you do with the, with the wall and the mesenteric side. And then we maneuver with the left mattock maneuver, clean it all, dissect the knives with the meds, went through and through again, squeezed it, and was completely, really lucky. Actually, the knife went between the 2 arcades, between the colon wall and the arcades. So I was really lucky in that respect. No way. There's no way that a CT triple contrast at that level and that height will have. Actually, we have 2 or 3 cases with negative CT rectal contrast here that has been really 48 hours, identify the leak, and has been horrendous consequence.
Perfect, excellent. And about the drain, probably I put a drain in this case, because you don't know about the kidney injury, can be a urinary leak. So I think you can put the drain, remove after 3 days like you did. Congratulations for excellent case.
Thank you. We don't like to put I don't like to drains. I'm not a fan of drains, but this one we put it intracapsular, just in case to drain quickly any pressure in the kidney. And then I was good. Thank you for your question.
Congratulations.
Thank you for your comments, Dr. Fraga. Bangkok, Dr. Super, your final comments, please.
Thank you, Dr. Afifi, for presenting this case. Excellent management and very good outcome. The patient is very fortunate to have you guys as doctors. Thank you.
Thank you, Dr. Super. Boston, Dr. Hoyman. I'm sorry. Go ahead, Dr. Afifi.
Yeah, hi. Thank you very much. We did the same like any seniors and Dr. Hoffman said. And now
well, yeah. Let me get Dr. Hoyman and Dr. Rizzoli's final comments. Is that okay?
Yes.
Okay. Thank you very much, Dr. Hoyman. Your final comments, please.
This sounds funny, but it's true. In the last century, Dr. Peralta and I were at Mass General together, and our management continues to be the same. I essentially, Dr. Afifi and Dr. Peralta did exactly what I would have done, nothing that I can add. So either we are both bad or good, I don't know. But I have really nothing to add. I congratulate you for an excellent result. I also wouldn't call urology for these cases. I wouldn't call urology if I have the ureter transected. I would put the double J myself and repair the ureter. If there is any concern about a leak later on, that's the time I might call urology to put endoscopically the double J. But otherwise, really, I don't have much anything else to say. Congratulations. Thank you.
But thank you for mentioning, we are well trained. I have a pleasure and privilege to work with you and train with you. And we did a lot of crazy things, and we changed the envelope in Mass General. I remember that. So we continue to do that for the benefit of the patient. Thank you.
Thank you for your comment, Dr. Hoyman. Dr. Rizzoli, your final comment, please.
Okay. So, first of all, Dr. Afifi, Dr. Peralta, thank you very much for putting this case together, for presenting it. Again, it shows our limitation, right? I don't think I would let I would treat non-operatively a patient who was stabbed near the colon, and the CT scan shows a wall hematoma and a possible colonic injury. So I think that that was the right decision. Looking back in retrospect, I wonder, right, if we knew that the colon was not involved, whether we could have used non-invasive procedures. I think it is possible, but it's possible only in retrospect. I think that with the risk of having a perforation of the colon, you must explore, and I think that that was well done, as well as the repair of the kidney and the repair of the diaphragm. Okay, good work. Thank you very much for the presentation.
As I mentioned, we sit with the radiology with review, and we saw that around 3 to 5 centimeters disruption and breach in the diaphragmatic. We know that he had a diaphragmatic injury we had to repair too, also, plus the colon and plus the heavy bleeding from the venous blush and the kidney. So we had to go in. Thank you.
Yeah, so yeah. I think, Dr. Zoli, we have more than one concern about for laparotomy. The colon is one of them. As you mentioned, if we go retrospectively, the question, can we do conservative management? But at the time, it's not only the colon we are concerning about. It is the colon, the active bleeding crystallization from the kidney, and it is the diaphragmatic injury. So it is more than a factor.
Yeah.
Gary,
I don't know if I would agree with you, Dr. Afifi. The bleeding from the kidney, as you said, is even venous, right? Most of the bleedings from the kidneys, they will stop on their own. And this diaphragm is very, very posterior. I wonder whether this patient benefit from the repair of the diaphragm at all. So I don't know. Again, I think that this case would open possibilities for non-operative treatment. Looking in retrospect, now that we know there's no colon injury, you could say, well, I could have treated the kidney differently. I could have treated the diaphragm, left the diaphragm. But I think that this is retrospect. I think prospectively, the case is the same.
Yeah, totally right. That's why we say that this is an interesting case, because the picture in respect and to the retrospect is different from the retrospect. So antegrade is different from retrograde. So, and that's why we had the dilemma of initially, if you repeat the case, Dr. Zoli, we have the same scenario.
So Dr. Rizzoli belongs to our family. So next time I will disconnect from the screen because he's a bias. But anyhow, he agreed with us that we need to go to the OR, and everybody knows that. Gary, we have one more picture to present. Please, one more slide.
Okay, stand by, please. Thank you.
Okay, fine. So this is when you're doing some search or some things, I mean, that we're always having the Eastern guidelines, we have European guidelines, and I have Brazilians also guidelines, and we have the Western Trauma Association guidelines. And I found that this is more constructed algorithm for the stab wound to the abdomen. It is published or that approved guidelines in 2018. And you can see here and simply and everywhere, if the patient hemodynamically unstable, or he have peritonitis, or he have gross blood in the nasogastric tube, we'll go to the OR. If not, we need to see if the patient is alert or not. Do chest X-ray. If there is free air, we'll go to the OR. Now, come to the right side, to the that side, the B side here. If patients have nothing of the above, we do evaluation by ultrasound. You can do local wound exploration. You can do ultrasound. You can do CT scan. You can do diagnostic laparoscopy. So diagnostic laparoscopy is not a rule in our case. It's a flank. And you see that ultrasound is a negative, FAST is negative. And a local wound exploration will not give us a value because we are not looking for peritoneal penetration. So we are in the positive side exploration, negative side, you go to the clinical pathway CB2, clinical pathway 2. And if it is equivalent to go to abdominal exploration or clinical pathway 2. So here you can see the classification, and all the seniors know that either the injury flank or back, or anterior in the middle here, or thoracic abdomen or upper abdomen. We are in the flank zone here. Let's go to the clinical pathway 3. So the clinical pathway 3 is here, and it showed that we must do diagnostic imaging, and that's what we did, because we have suspicious symptoms or something like this. So everyone agreeing for this, and CT scan done. And the question CT scan, do we have any signs to operate? Yes or no? And if there is signs need to operate, then we have to operate. Otherwise, we will not operate. So clinical pathway 1 is usually local wound expression or operation directly. And clinical pathway 2 is the local, this is serial abdominal examination. So we're always having the pathway number 1, which is they go to the OR, pathway 2 is conservative, and pathway 3 is further assessment of pathology. In here, the red one, it is next slide. The potential in major morbidity mortality is there is a risk of retroperitoneal structure, visual organ injury, bowel, colon, duodenum, always in the flank stab wound. CT scan is recommended. The triple contrast versus double contrast is still final consensus was decision should be made at discretion of the surgeon and the radiologist according to the scenario as we mentioned before. Now, if you have, what is the signs of operative injury in the CT visualization? Do you have bowel injury? I think that time we're having suspicion of chronic hematoma, and this is the important issue. And we mentioned before, even if the negative, we still have negative, triple contrast, we still have equivocal for us from our experience. And as Dr. Hulman said that this is heretical nonsense. The secondary signs, it's important that if they have free fluid unexplained, we don't have a free air, bowel wall thickness again is another one, and mesenteric injury, and a contrast extravasation including ongoing bleeding. It is a secondary signs where the patient can be taken to the OR. I just have this is my last slides, and I have my last comment. This is the patient after we did everything, surgeon, and he will take the approval for him. And I think even consult management, there is no rule of the angioembolization with the venous blush or the venous and red blush. So the angioembolization is out of the equation. And we have been sure that we don't have ureteric injury from the CT scan, especially in the right face, being continuously a good one. And the hematoma is the lower bowl of the kidney. It's not including the pelvis. We have to immediately involve the urologist because of the follow-up. My last thing that, in this case, we are going to follow up CT scan angio for the abdomen. And the reason that I was chatting long back again with our colleagues from urology, and they said to me that they are facing some cases of grade 3 plus of the kidney later on the developing pseudoaneurysm. So this case, based on their recommendation, and the studies have to go for, maybe we are going to follow up the patient for CT scan after 1 month or after 3 weeks in this case. Dr. Rubin, you want to say something?
Well, thank you for your comments. On behalf of the Team Qatar, we'd like to thank you for your attention. And take it away, Gary.
Okay, thank you, sir. I'd like to actually give it over to Dr. Martos.
Yes, good morning. Another great presentation from Team Qatar. Happy to see everybody connected, and Dr. Afifi did a great job. I was very impressed with you when I was in Qatar doing the pre-decision trauma course, and you are keeping high expectation every time you talk, and you deliver today. Congratulations, Dr. Afifi. Dr. Rizzoli, Dr. Peralta, congratulations for creating this nice team, having these nice fellowships, and they are ready and they are showing great things in worldwide. Looking forward for next week. And Dr. Supa and other colleagues, please talk to Valeria to schedule your presentations. You have been learning with each other for more than 11 years. Like Dr. Fraga told me in the WhatsApp group, we have hundreds of cases already. We're always learning to each other. That's the goal. And that's the goal of the Pan-American Trauma Society. Thank you very much, everybody. See you all next week.